Dear friends, I would thank Pascal for inviting me for the first time at the nurse and PA meeting. And I would share with you my experience of Bankart repair and Hill-Sachs remplissage. Hill-Sachs lesion is identified in more than 80% of unstable shoulders. And when it is large and engaging, it is responsible of a dramatic increased rate of recurrence after an isolated Bankart repair. Connolly in 1972 described an open procedure which consisted in a detachment of the infraspinatus and reattachment into the Hill-Sachs lesion. But it's Eugen Wolf in initial course 2004 who first described of an arthroscopic procedure which included an arthroscopic Bankart repair and Hill-Sachs remplissage, which is a French word emerged from his French training in Bordeaux. The principle is to fill the humeral defect with the infraspinatus tendon and the posterior capsule, which is like a capsulotenodesis of a Hill-Sachs lesion. So we can make a Hill-Sachs lesion extraarticular, and this option seems to be attractive. This is an example of a Bankart repair and Hill-Sachs remplissage in a left shoulder for a patient with an anterior instability without glenoid lesions. The patient is in a big chair position, and we're gonna enter the shoulder with a soft point, posterior soft point. The first step is to prepare the Bankart repair, to release the labrum and the capsule, as you can see here, and refresh without increasing the anterior bone loss, the glenoid neck with a shaver. We will put a TOT with a traction outside suture to shift the capsule from the south to the north, and then put the first anchor at the 5 or 5.5 o'clock position, as you can see here. So this is the first anchor, which is a lower anchor, and we'll put the first stitches of the labrum reinsertion at the lower part. So when this suture is prepared, then we will shift from posterior view to the anterior view, and we're gonna prepare the Hill-Sachs lesion. We're gonna use a needle to create a posterior portal directly in front of the Hill-Sachs lesion, and through a cannula, which is not inserted inside the joint, but just in under the deltoid, we will refresh the lesion and put two anchors. We're gonna use the same anchors than we use for the Bankart repair, which is an impacted anchor, and then put two sutures, which is a mattress sutures. The two anchors are positioned at the lower and higher part, as you can see here. So we prepare now the remplissage without tightening the two suture, because if you tighten the two suture at this step, we will not, you will not be enter inside the joint anymore, because the capsule is too tight. So we're gonna prepare, as you can see here, and then shift another time from the anterior to the posterior portal. And then we're gonna finish and finalize the Bankart repair. We will tighten the first suture and use the traction outside suture to shift the capsule and to put 2 or 3 more anchors. It's this step of procedure is really classical. We use only 1 anchor per suture, but you can use, of course, 2 anchors, 2 suture per anchors. It's just a philosophy, 1 suture for 1 anchors in my practice. So now we will recreate the bump effect. We'll reinsert and recreate the anterior labrum, as you can see here. When this step is finished, we will shift another time from posterior to anterior portal, and we're gonna tighten the two mattress to fill the defect, as you can see here. And this is the final view with a perfect remplissage of the Hill-Sachs lesion. So in a single center case series, we would report our experience of this technique at midterm follow-up and highlight what were the predictive factors of failure. We included patients for traumatic anterior shoulder instability treated with Bankart and Sachs remplissage with a minimum follow-up of 24 months. We excluded revision surgery and if the instability was voluntary. We excluded as well unstable and painful shoulder. At minimum follow-up of 2 years, 5 out of 44 patients failed. I mean, they had a recurrence of instability, subluxation or luxation, which is more or less 15% of the series, and 2 more patients had persistent apprehension tests. Mean throw score and duplex score were more or less 90 point and 20 points at follow-up. And we did not found any restriction, any stiffness in external rotation position 1 and 2, only 6 degrees in adduction and 1 degree in abduction. After statistical analysis, we found that deep heel sacks had higher risk of recurrences than the others, especially when the deepness was greater than 20%. The second prognostic factors were the way to recover range of motion in post-op. I mean, when a patient had a greater range of motion at 6 weeks, he had higher risk to fail. We developed a pure mathematical model, and we found that the pull-out strength on posterior capsulotenodesis was higher in case of deep heel sacks lesion. That was one explanation why we had a high rate of recurrence, not because it was large, but when it was deep regarding the heel sacks lesions. So to conclude, Bankart and heel sacks remplissage can really work if we have no glenoid bone defect and in case of a small heel sacks lesion. Our experience reported higher rates of failure at midterm follow-up than it is commonly reported in the literature. Premature recovery of range of motion is for us a clinical sign of failure at follow-up. So the limit of Bankart heel sacks remplissage is a deep heel sacks lesion. And if you have a lesion deeper than 20% of the humeral head, you should choose another option. Thank you for your attention. I hope to see you in December for the next meeting of the French Arthroscopic Society.